Good afternoon. It's with the greatest pleasure that we bring you the 7th lecture in the McGill Palliative Care National Grand Rounds series. With the generous support of 10 local hospital foundations and Pallium Canada, we intend that this initiative builds on the historic contributions by McGill University to the field of palliative care by providing a novel means to disseminate the latest innovation, research, and ideas in our field to places across Canada and beyond who may not typically have access to the types of speakers who typically present within the walls of our academic institutions. Before welcoming Dr. Stephanie Gingras to introduce this lecture and before providing accreditation-related information for this lecture and the National Grand Rounds program, we wish to acknowledge the land on which this lecture is given.
Thank you, Justin. Bienvenue à tous et à toutes. The members of this committee and their relevant declarations include Dr. Justin Sanders, who has relationships with La Maison Saint-Raphaël, the American Society of Clinical Oncology, and Connections, Inc., and who has received honoraria and grants in recent years from the Oklahoma University of Health Sciences, the Oregon Health Sciences University, and Pancreatic Cancer Canada. Dr. Algeri Timikalis, who discloses a relationship with and grants from the Shriners Hospital for Children. Dr. Olivia Nguyen, who acknowledges an association with la Société québécoise des médecins de soins palliatifs and a research subvention from la chaire de la famille Blanchard pour l'enseignement de la recherche en soins palliatifs. Dr. Naomi Goloff, who reports relationships with the Canadian Society of Palliative Medicine and grants from the Kindred Foundation and l'Association québécoise de soins palliatifs. Dr. Zelda Freitas, who indicates grants and relationship with the Canadian Centre for Caregiving Excellence and with Nova Montreal, and Drs. Janelle Walsh, Aurel Schuker, and myself, who have no conflict of interest to disclose. This series includes sponsorship from the Cedar Cancer Foundation, the Hope and Cope Wellness Center, the Jewish General Hospital Foundation, the Montreal General Hospital Foundation, the Montreal Neurological Institute, the MUHC Foundation, Pallium Canada, St. Mary's Hospital Foundation, the Montreal Institute for Palliative Care, a branch of the Teresa Delard Palliative Care Residence, and the Montreal Children's Hospital Foundation. Special thanks to the Department of Family Medicine at McGill University for their in-kind support. Here we present a strategy to mitigate potential bias. The overall program learning objectives are as follows: to review innovative approaches for the implementation of palliative care in different settings, to assess strategies to address the most important challenges in palliative care today, and to appraise the latest research in the field of palliative care. Now, please welcome Margot Watine of the Montreal General Hospital Foundation to introduce today's lecture and the person for whom it is named.
Thank you. Hello, I'm Margot Watine. The Montreal General Hospital Foundation is proud to sponsor this Dr. Jane Poulson lectureship as part of the McGill Palliative Care National Grand Rounds. Thank you all for being here today, and thanks to all our generous donors for making this happen. You have our deepest gratitude. Our mission is to inspire the philanthropic community to invest in transformative initiatives conceived and guided by our medical leaders that have a significant impact on patient lives. In doing so, we advance the pioneering spirit of the Montreal General Hospital, which joined forces with McGill University to form Canada's first teaching hospital. Speaking of pioneering, let me tell you about the woman for whom this lectureship is named, Dr. Jane Poulson. Indeed, Dr. Poulson, whose many accomplishments include establishing a hospital palliative care program, was a vibrant force whose compassion and optimism inspired the medical students she taught, her patients, readers of her articles, and later her autobiography, as well as her beloved friends, family, and everyone who crossed paths with her. Diagnosed with breast cancer, she passed away at 49 and surrounded by all her loved ones. Due to diabetes, Dr. Poulson became blind in her late 20s and is remembered as the first blind physician to practice medicine in Canada. In fact, her autobiography is aptly named "The Doctor Will Not See You Now." The Dr. Jane Poulson Lectureship Series was made possible by generous donations to the MGH Foundation at the time of her passing. She started her career with her right here at the Montreal General Hospital. And to quote Dr. Phil Gold, who unfortunately was not able to join us today, he said she was a singularity. It seems to me that our speaker today and Dr. Poulson would have been kindred spirits. I know that you will enjoy hearing from Dr. Max Chochinov. Thank you.
Thank you so much. Before I introduce our speaker, I just want to acknowledge that because of some of the turbulent times we're in, we've disabled the chat function, which is usually open for people to comment through the lecture. We've had some experiences recently that, out of an abundance of caution, leave us to close the chat. And so I wanted to alert people to the possibility and mechanism for translating using closed captions. So first of all, if you are attending to your Zoom screen, you can select Show Captions at the bottom of your screen. You can make sure that the translation button is switched on. And then if you hover over My Speaking Language and select English or French, or if it's something else. And then if you hover over My Caption Language and then select the language for which you wish to see the captions. Actually, you should choose English for the My Speaking Language. But over the caption language, select the language that you wish to see the captions in. So I hope that that's clear, and I'm sorry that we're not able to put those instructions in writing as we typically are. So it is my great pleasure to introduce the speaker for the McGill Palliative Care National Grand Rounds, Dr. Jane Poulson Lecturer, Dr. Harvey Max Chochinov. Who is, I'm certain, familiar to many of you. Dr. Chochinov is a distinguished professor of psychiatry at the University of Manitoba and a senior scientist at Cancer Care Manitoba Research Institute. His research in palliative care has resulted in more than 350 career publications, which have been cited nearly 30,000 times, broaching diverse topics such as depression, quality of life, suicide, vulnerability, spirituality, and existential distress. He has also led a large program of research on dignity within the healthcare setting, which includes the development and study of dignity therapy. He is the co-founder of the Canadian Virtual Hospice, co-editor of the Handbook of Psychiatry and Palliative Medicine. His latest book is entitled Dignity in Care, The Human Side of Medicine, published by Oxford University Press. He is an officer in the Order of Canada and an inductee into the Canadian Medical Hall of Fame, and there are few Canadians who have contributed as much to the practice of palliative care in Canada and beyond. So I'm delighted to welcome Dr. Chochinov today.
Thank you and welcome everyone. I'm just going to quickly go through these administrative slides, no conflicts of interest. These are the CanMed's competencies that I've identified, and these are the learning objectives that I hope will become imminently obvious as I go through my talk. So I am deeply honored to be your guest speaker today, and of course to be delivering this lecture in memory of Dr. Jane Poulson. I can say that my career has afforded me many opportunities, including the opportunities to meet many of the luminaries in palliative care, nationally and internationally. It's impossible to be here at McGill and talking about palliative care without paying homage to Dr. Balfour Mount, who is considered the father of palliative care in North America. I also had the opportunity many years ago to meet Dame Cicely Saunders, who many of you will know is the founder of the modern hospice movement. This particular photograph was taken the very first time that I met Dame Cicely. I stepped into her office. Irene Higgins, who a wonderful palliative care researcher, snapped this photograph. And in case you're wondering why the two of us look so happy, I'm not sure it was because Dame Saunders was happy to meet me, but the fact that this was her liquor cabinet back here. These were empty sherry glasses. And the only question that Dame Saunders asked me at 10 in the morning was, would you care for a sherry? And even though I was about to step into giving a lecture at King's College for the entire faculty, when Dame Saunders says, would you care for a sherry? There is only one answer. And the answer is, of course, yes. The last time I was in London, I spoke as well at King College and then went on as a guest speaker at Oxford University. And I met this gentleman who also was an incredible luminary in palliative care. And this is the late Dr. Robert Twycross. And Dr. Twycross is the first person who was apparently hired by Dame Cicely when she started her efforts at the hospice that she founded. And he is very well known for having done some of the important and foundational studies in the examination of opioids for cancer-related pain. So all of these people, I would say, were pioneers in the area of understanding human suffering. And I think whenever you invite a palliative care researcher from Canada to talk about palliative care, they will inevitably show one of the paintings by Robert Pope, who is this wonderful artist from Eastern Canada, who, as he was approaching his own death, created this magnificent series of paintings. This one is perhaps less well known, but one that I have been using of late because to me, it is an image of somebody who is teetering at the water surface. And it begins to make you wonder, what are the forces that keep people buoyant? And what are the undercurrents that threaten to pull people under? And so I have been thinking about those issues and issues of human suffering. And to some degree, some of my research has taken place in the shadow of questions around death hastening, euthanasia, and assisted suicide. 30 years before any decision in the Supreme Court, Carter versus Canada, we in our research group had looked at what was happening in the Benelux countries with respect to medical decisions to end life. And particularly, as a psychiatrist, I was interested in knowing what is the motivation for people who are approaching end of life and actually have their lives ended in a way that is hastened by a Dutch physician. There was a wonderful paper published by Paul Vandermas in The Lancet, in which he not only reported the prevalence of medical decisions to end life, but he identified on the death record the physicians who were involved in these death hastening acts, and then interviewed these physicians to say, why is it that you think your patient walked this particular path? And lo and behold, loss of dignity was the most highly cited reason, more so than anything else that he could discern from these Dutch physicians, which for me said, if dignity is worth dying for, then dignity is worth studying. And when you looked at the literature, there were no empirical studies of dignity in the terminally ill, even though it was highly cited and highly politicized. So people would use it on either side of the political fence to say, if on the one hand, you thought that assisted suicide and euthanasia was something that should be available, it was a way of helping patients express their autonomy and control, you say that this is a fundamental dignity issue. And in the opposite side of that political fence, you'd say this seems to be a violation of the Hippocratic Oath that undermines perhaps the patient-doctor relationship, and the taking of human life seems to be an assault on human dignity. We said, we're not the moral police. We don't have a political axe to grind. Really, our motivation is to do something to try and understand how we can deliver better end-of-life care. And so we began doing studies on dignity, and this is one of the first studies that we published. We designed an outcome measure based on an instrument called the Schedule of Affective Disorders and Schizophrenia, just a way of being able to help patients rate their sense of dignity. And what you notice is that in half of instances, there was no loss of dignity reported by these patients. And this was a group of over 200 patients in palliative care. Which means that at least in the remaining half, dignity is a salient issue. In other words, it's something that we need in palliative care to be mindful of. And then there was this small minority in which it was a significant ongoing problem. Now, because this was quantitative work, we could then do some fancy analysis and start to look at what differentiates people whose dignity is intact versus those whose dignity is broken or fractured. And some of the things that were reported is that, they seem to have more physical problems, more pain, more psychological problems like depression, anxiety, loss of will to live, heightened desire for death, and difficulty with what we labeled the intimate dependencies of care, bathing, dressing, toileting. But when we then asked, is there something over and above all others that is most predictive of variance in will to live, of dignity? What we found is that appearance, how people experience themselves to be seen by their healthcare provider, was the most ardent predictor of sense of dignity, which to me was kind of my first, I would say, research epiphany. Because up until then, I thought that good palliative care had to do with what we did to patients or with patients. And the data was now saying the way we see patients, what goes on between our ears as clinicians has an influence in shaping the patient's experience. So in this separate article that was published in the Journal of Clinical Oncology, even though it's based on empirical evidence, metaphorically, what I argue is that patients are looking in the eye of the healthcare provider for a reflection that will be affirming of their sense of dignity, of their personhood. And then years later, I discovered this etching. I think it's really a compilation of two etchings by M.C. Escher, a Dutch graphic artist. And I choose to call this a reflection in the eye of the healthcare provider. This is a self-portrait. So you see Escher in his apartment, surrounded by his belonging, his books, his photographs, and the like. This is an affirmation of the artist, as opposed to what patients might sometimes experience, which is seeing their illness, that they're become the embodiment of their illness, or seeing a differential diagnosis or a problem checklist, which, as I've written, then leads you to the problem of patienthood eclipsing personhood. And of course, what we know about human suffering in the writings of people like Eric Cassell is that when people sense that personhood is under assault, suffering becomes profound and commensurate. So if we're saying that the gaze of the healthcare provider is important, then we need to think about, well, how is it that we see patients and what shapes the way we see patients? Because that's going to have this profound impact on patient experience. And so we began to look at that, beginning with trying to understand this issue of desire for death, patients reaching a place in their lives where they no longer want to go on or feel like dying sooner than later would be a good outcome. And what we reported in this early study is that 80% of people who had a desire for death reported pain of moderate severity or greater. They reported that their families were less supportive or available. And they reported that syndromal depression was present in the magnitude of about 70% compared to somewhere around 10%. The numbers you can locate in the open access articles, and all of my articles are open access. But it's the fact that to understand this experiential landscape, you need to understand whole persons. In other words, from a multitude of vantage points, you need to understand what's happening physically, what's happening emotionally, existentially, spiritually. And you need to understand in that person's environment what's going on that might reinforce or undermine a sense of will to live. And speaking of will to live, we did a separate study that was also published in the Lancet, in which we added a will to live visual analog to the Edmonton Symptom Assessment Scale. So we simply had people rate on an ordinal scale from 0 to 100, how would you rate your will to live? And anything that scores high on the ESAS is indicative of distress. Again, there were a couple of hundred patients in this study. I've parsed out one particular case example. This is an 80-year-old woman with colorectal cancer. When she enters into palliative care, in yellow, you can see her will to live is poor. It immediately improves. It stays improved until she approaches death, at which times it becomes more erratic or more erratically reported. When she's no longer competent, she can't give meaningful data, we stop collecting information. And what you can see is this allows you to superimpose her subjective experience. In this instance, I've graphed her pain vis-a-vis her will to live. And again, if we were to use a dance metaphor, this is a tango, this intimate connection between her experience of pain and will to live. And while we can't talk about cause and effect, we can say that perhaps, as we improve her pain, so too do we improve her will to live. Or now that we have given her the kinds of support she needs in an inpatient palliative care facility, we've also been able to mitigate her pain experience. Also, just to point out that even though in medicine we tend to silo these things out, the pain specialist, the pastoral care specialist, and so on, these things happen in whole persons. So the fact is that treating pain can have profound and measurable spiritual outcomes. As of late, I've been thinking more about this issue of loss of will to live or desire for death in terms of another construct that's emerged from our research, which has to do with a sense of fractured personhood or a feeling of brokenness. One of the things that patients identified as a profound issue was no longer feeling like I'm the person that I once was. And so I began wondering, well, could it be that fractured personhood, although that seems to have an influence on desire for death in palliative care, might it have an influence across the entirety of the human life cycle? In other words, understanding fractured personhood might provide insights on the dynamics of understanding suicidality. And so just a couple of months ago, this was in the Canadian Journal of Psychiatry, we published for me was a full circle moment, because I came into this work because these Dutch physicians had reported loss of dignity in patients who sought out a hastened death. In this study, we looked at patients who were in a psychiatric facility, used our measure of dignity distress, the patient dignity inventory, and found that there were strong and significant correlations between loss of dignity and suicidality. And so at the very least that it says is that we need to understand the dynamics of dignity in patients who are anticipating taking of their own life, whether they are near the end of life or at some other point in their life. To summarize in some ways, this graphic really says that medicine has become very transactional. And if we think of the transactional elements of medicine, we try and understand physiology, pathophysiology, diagnosis, differential diagnosis, problem checklists. And at the center of it all is still a patient who is yearning, needing to be seen. At one point, to try and really kind of reinforce the lessons coming out of this research, I published an article in the British Medical Journal in which I called the ABCDs of dignity conserving care. And I kind of borrowed this idea from the ABCs of critical care in medicine. None of us are absolved from the responsibility of knowing if you come to the aid of an unconscious patient, you need to think about A for airway, breathing, circulation. And yet when it comes to the humanities of care, we say there, trust your guts, be a kind person, if there is time. And yet it seemed to me that there should be core efficiencies that as healthcare providers, we're all responsible for. Again, there's not time to go through this in detail, but A is for attitude, and I've already shown you the way in which attitude, empirically, we've shown has a profound influence on experience. B is for behavior. Do you sit? Do you stand? There have been randomized controlled trials of sitting versus standing, believe it or not. And what they've reported is that without changing anything else, if the physician sits at the bedside rather than standing, the perception of the passage of time is increased exponentially, and the rate of satisfaction is about 90%, versus a much less distortion in terms of perception of time and only a 40 to 50% satisfaction rate. C for compassion, this idea of understanding the suffering of another person. And I underscore the word person. You can't attend to suffering without understanding some essence of who that person is, and an attempt to try and mitigate their suffering. And D is for dialogue, conversations, ways of trying to elicit personhood. So let's go back to Dame Saunders, who said, "You matter because you are you, and you matter to the end of your life. And we will do all that we can, not only to help you die peacefully, but also to live until you die." So it seemed to me that, this has become the central tenet of palliative care. But what Dame Saunders didn't provide was a how-to guide. How do you attend to someone who feels like they no longer matter? And so last year, or no, it was the year before, I published this article in the Journal of Clinical Oncology. And it really borrows from the idea of intensive care. When somebody is in dire straits physically, we offer them intensive care. Well, what if the nature of their distress is not physical, but psychological or spiritual or existential? That's where the idea of intensive caring came to me. And what I'd like to do in the remainder of my time is to go through the core tenets of intensive caring. And this is the kind of care that we hopefully invoke when we are stepping into situations where people are suffering, where they might feel like they no longer matter. Or as one patient I had said to me, breathing has become redundant. So the first tenet of intensive caring is non-abandonment. The dynamics of abandonment in medicine, not just palliative care, but all of medicine, is a feeling of impotence, is a feeling of helplessness. I don't know what to do, and therefore I'm not going to enter into a situation where I'm going to feel this overwhelming sense of helplessness. The first tenet of intensive caring says, get over yourself, show up. Showing up makes a difference. And by showing up, you can make a quality connection and you can provide ongoing support. There's a wonderful study by Kelly Trevino, an American oncologist, who looked at correlations between physician connectedness with physicians and suicidality, and found that that connection was the most ardent predictor of suicidality over and above even things like psychotropic medication. So in case you're wondering, showing up, that doesn't seem very profound. Well, the evidence shows that it makes a difference between coveting death and not coveting death. Dame Cicely also said, by the way, that suffering is only intolerable when no one cares. And you can, add to that, by the by, when no one shows up. The second tenet, taking an interest in the person, and that, of course, is going to enhance empathy, respect, connectedness, and provide you with an opportunity to affirm their worth in terms of who they are, who they were, who they try to be. We in our work have tried to invoke different ways of eliciting personhood. Probably the most studied non-pharmacologic palliative care intervention studied at this point is something that we've called dignity therapy. It's based on the notion of generativity. It guides a patient through a conversation that allows them essentially to say the things that they would want said, the things that they would want known, perhaps the messages that they would want to leave for those people who will soon mourn their death. And this is just a photograph of the first trial that was conducted in Canada and Australia on dignity therapy. To give you a flavor of what that looks like, there was a woman that I was asked to see not so long ago. And as tragic as you can imagine, this was a young woman, young marriage, young child. She had heard about dignity therapy through her social worker and came to me saying, I need to do this because my child I will not live long enough for my child to remember who her mother was. And we had a conversation. I was able to guide that conversation. It was recorded, it was transcribed. She was able to provide some, critical milestones, memories that she wanted to leave for her child, some words of wisdom and guidance. Even giving her husband permission to find a new partner with the proviso that whoever he found would love her child the way a mother is meant to love a child. So we gave her this document, and she said to me, this helped my child to prepare my child for life and help prepare me for death. I think the other important thing about the story is that when you enter into that kind of work, you think, it's easy to feel overwhelmed. But if you have the right tool, and in this case, there was no question, this was the exact tool that this woman needed in order to accomplish something that couldn't be accomplished otherwise. Not everyone needs dignity therapy. Dignity therapy is not a panacea. It requires a certain amount of time and resource. But every patient, not only in palliative care doesn't have a monopoly on dignity and the importance of dignity and kindness and compassion. It's important throughout all of medicine. So we have introduced something that I call the patient dignity question, which essentially asks, what should I know about you as a person to help me take the best care of you that I can? To study this, we go to the bedside. We say, we know an awful lot about you. From your medical chart, we know very little about who you are as a person. So tell me, what should I know about you as a person to help me take the best care of you that I can? And that is meant to elicit a 5, 10, at most 15-minute conversation, which is focused on personhood. We then summarize that into a couple of paragraphs, and we come back to read it, give an opportunity to make any editorial changes. And the litmus test, do we have your permission to place this on your chart? We've now done studies with a few hundred patients. There have now been studies that have been published of several thousand patients. In every instance, I've never heard when a patient said, no, I don't want that information that says this is who I am to be placed on my chart. This was data taken from patients who participated. And what you see is that, and these are really rounding errors, it was always accurate. All of them, without exception, said it needs to be on my chart. They thought it was important information for their healthcare provider to know, that it might affect their care, and they would recommend it to others. Healthcare providers who read this, by the way, not only reported heightened job satisfaction, but in 90% of instances said, I learned something I didn't previously know. And even though these were palliative care clinicians who are wired for empathy and compassion, in 45 to 65% of instances said, this heightened my sense of respect, of connectedness, of empathy. During COVID, we actually did a PDQ study in intensive care. So the clinicians would contact the family member whose loved ones were now unconscious or on a ventilator in intensive care, say, we have some researchers who would like to speak with you. Because of COVID, we called them on the phone, and we had these short conversations focused on personhood. This is taken from a PDQ document. Terry was the daughter speaking about her mother, and it says, Terry wants the healthcare team to know that her mother is not any ordinary patient, but a very special woman. Quote, since my mother was admitted, I've been struggling to find a way to share my mother's story with the staff, but my heart is so happy that this PDQ will now allow me to do so. I hope the staff read my mother's story and appreciate the life she lived. And this just shows you when I think we had about 33, I think it's 35 when the study closed. And essentially, we had people rate their experience on an ordinal scale. 5 is as high a rating as you can get. And you can see that everybody said it needs to be on the chart. It's accurate. It's important. They found it emotionally affecting and recommended it to other family members. This has now been translated into over 20 languages. When you think about, again, the healthcare provider lens, intuitively, when we think, well, what is it that somebody might need? Oftentimes we defer to the golden rule. We say, well, if I can do to you what I would do to myself, that ought to be a good gauge of how I should proceed. And that is True, except that we do have to admit that it imposes this external standard, which in some instances might lead to therapeutic nihilism. Would I want to be that old, that sick, that marginalized, that vulnerable? So it could then lead to advice based on avoiding a future that the healthcare provider would find untenable, which in turn is going to lead to discordance in goals of care. So for that reason, I introduced this idea of the platinum rule, doing unto patients as they would want done unto themselves, which is not to say all people get all things at all times. And the article, describes that, but it does say the lens that matters most is not yours, but the lens that the patient sees the world through. This is a photograph of my sister, Ellen. Ellen died 16 years ago. She was born with cerebral palsy. She had all of these sequelae of cerebral palsy that you can imagine, including kyphosis and scoliosis, terrible respiratory capacity. She couldn't blow out her birthday candles if her life depended on it. We all helped her, mind you. So she died at the age of 55. Several years before her death, she was once again in intensive care. And on the brink of whether or not her intensivist was going to have to intubate her. And at one point, the intensivist came up to me and asked me the only question that he was to ask about personhood. He said to me, "So does she read magazines?" And I thought, that is a really wonky question. I mean, my sister's life hangs in the balance, and you want to know if she reads magazines. And then it occurred to me that there was a subtext. And the subtext had to do with the fact that he could see her scoliosis, he could see her dropping blood gases, but he couldn't see Ellen. He didn't understand this woman who had a complex life, but was deeply loved and loving. And so I took a moment and said, well, yes, she does read magazines, but only when she's in between novels. So the point is, always consider the patient's perspective, and that means recognizing and confronting your own personal biases. It's also important when it comes to substitute decision-making. The correct question when you're coming into the room of a patient who no longer can speak for themselves is not, what would you want us to do for your mother or your father or your sibling? The correct question is, if we could bring that person back into the room the way they were a week ago or a month ago, what is it they would want done? And I would argue that's a platinum standard, and that raises the bar on person-centered care. The next tenet of intensive caring has to do with tone, what I call dignity-affirming tone. I had a mentor, his name was Dr. David Bowman. He would walk in the room, and without saying a word, you knew that he was there, he was present, and he was attentive and not distracted. These elements of tone were taken from a study we did on optimal therapeutic communication. And again, the studies are available in open access. Empathy, non-judgmental, authentic, trustworthy, fully present. It's so easy in this day and age to be distracted. We walk in with the world, at our fingertips. We need to put the world aside. And if we only have 2 minutes, to take that 2 minutes to be fully present. The next tenet is knowing what's possible. It's very easy to, hopelessness is contagious. Our patients might feel it, their families might feel it, and we ourselves can begin to feel it, to be asking ourselves, well, what is the point? So to know what's possible, conversations, reconciliations, preparing for a time when this person will no longer be here. My mother died 3 years ago. I remember my older daughter walked into her room when she was literally on her deathbed. And I heard the last thing that I remember Lauren saying to her grandmother was thanking her for making her entire life better. It means something. We're also doing a study now in which we're asking patients who've been approved and are waiting for MAID why they're following this path. And I remember, not so long ago talking to a man who had been approved for MAID. And I said, and what was his reason? His grandmother had had a terrible death, and he was not going to walk that path. And when I asked him how long ago his grandmother had died, 30 years. For 30 years, this man had carried this map in his head of what dying looks like. So even remembering that the way somebody dies is demonstrating, is forming a template for those who bear witness, gives you an idea of what is possible at that time. And then finally, there's this issue of humility. You're walking into situations for which you don't have a readily available fix, which means you need to learn to be comfortable with clinical ambiguity, honoring and accepting the patient's expertise, trusting in the process, and avoiding the need to have to fix. The article says therapeutic humility sees notions of fixing yield to commitment to understand the nature of the patient's suffering while creating a safe space to bear witness, to validate, and to comfort always. So what I would say to you is that this notion of intensive caring, to my mind, really is kind of like a paradigm shift. I mean, the traditional medical paradigm sounds like this: we examine, we diagnose, and we fix. It's the reason most of us went into medicine. But life teaches us, and certainly practicing medicine teaches us, that not everything fits into that paradigm. And unless we're prepared to just kind of excuse ourselves from that, to dismiss ourselves from that and say, well, we better call the social worker, or we better call, go speak to your spiritual care provider. If you're going to practice medicine, cognizant of being attendant to suffering, intensive caring says that examination yields to finding out who is this person. Diagnosis yields to finding out about the nature of their suffering. And fixing finally yields to providing comfort and being with. The article ends, as this talk nearly will end, with the following. It has been more than 50 years since Dame Cicely shared the wisdom informing this clinical approach. Decades later, when medicine's reach to fix exceeds its grasp, the time to consider the role of intensive caring is now. Now, just before I end, and I'll take one more minute, 2 years ago, the dean, who's wearing this very nifty orange tie, honored me by asking me to deliver the white coat ceremony. This is the time when the new medical students come in and for the first time they put on their white coats. And I was their guest speaker. I don't know what I'm more proud of, the fact that he asked me to give this talk, or the fact that at my age, I figured out how to make a QR code that I embedded into this PowerPoint presentation that you can do something with, so I think you can actually see the full thing. I didn't read that part of I just figured out how to put this in here and stop reading. So let me leave you with a few of the messages that I left with these medical students who are just beginning their journey in medicine. I said to them, and I say to you, strive to be more than human body mechanics. Aspire to be healers. Next, I said to them, and I say to you, the way we are with patients and our attitude towards them will profoundly shape every single clinical encounter and their illness experience. Next, I said, patients will not care what you know until they know that you care. And then finally, in closing, I leave you with this. In exercising kindness and compassion in every clinical encounter with every person whose path you cross, you are playing your small part in bending the arc of the universe towards hope, healing, and peace. That's my book. That's my contact information. Happy to answer questions. And if there isn't time, please contact me and we can continue the discussion offline. Thanks so much.
Thank you so much, Dr. Chachinov. We have a question on Zoom. Here it is. I'm wondering if you can share how to define dignity when you're asking respondents, to rate and comment on dignity for research studies. What is your working definition and has it changed over time?
A great question. And it's a question and sometimes that I feel like I have perseverated over for not just years, but decades. So initially, when we started to examine the issue of dignity, the very reason that we did it is because like the questioner, we said, well, these Dutch physicians have reported this, but what does it mean? And they weren't given an a priori definition of dignity. I mean, a dictionary definition is this idea of being deserved of honor, respect, or esteem, which, as it turns out, isn't a bad definition. When we went into the work, we started in a simplistic way by simply getting people to rate it on an ordinal scale, and I reported that data. But we realized that really wasn't sufficient, because dignity is much more complex than simply rating it, from 0 to 10. I mean, it would be like my claiming that, I can study love just by rating it from 1 to 10. And if I do all the correlations and its associations, we don't need Shakespeare. Well, that's ridiculous. So what you need to do if you're going to understand dignity is qualitative research, which we did, in which you do a deep dive and you ask patients what it means. How do they understand it? That yielded an empirical model of dignity in the terminally ill. So what has evolved over time is that when I think about defining dignity, I think dignity means different things to different people. How do we know what those things are? The constituents of dignity are contained in the model of dignity in the terminally ill. The model is not hierarchical, which means that some elements of that model have to do with, keep me clean, keep me pain-free, and other elements of that model have to do with spiritual issues and existential issues or relationship issues. So that is the way in which I have studied dignity, and that's how my understanding of dignity has evolved over time.
Thank you. Thank you. We're going to take questions from the audience or comments.
Thank you, Doctor. What a very inspiring, compelling talk. Thank you so much. You had a great quote from Dame Cecily 50 years ago on dignity, and she's inspired us. What's your vision for the next 50 years? Where will we be 50 years from now?
Oh, I can tell you what I hope, but where we'll actually land, who really knows? Especially in this day of AI and things being replaced in a way that we're not all entirely comfortable with. Although some of the applications of AI seem to possibly be opening up approaches that may actually enhance person-centered care by freeing up human beings to spend more time with other human beings and do some of the other work behind the scenes. I say that because I'm thinking of my 95-year-old father, who I continue to take to doctor's appointments. And there are some physicians, I swear, who I don't think could actually pick him out of a crowd because their face is buried in a computer. And if we could free clinicians up so that they can actually have eye contact and be more engaged, well, AI takes care of some of the documentation that they're so worried about. Maybe that will enhance things. The direction that we've seen medicine, on the other hand, move in is more towards the transactional. And the problem with transactional medicine is that it happens at the exclusion of the relational. And the problem with that, of course, is that even though that may, look like heightened efficiencies, the people that we're putting through the system are still people. I wrote an article years ago called "The Secret is that Patients Are People with Feelings That Matter." So we need to be mindful that, the transactional and trying to be efficient around the transactional is important. But if it happens at the exclusion of the relational, then people are going to feel somehow, personally assaulted. So my hope is that eventually the transactional and the relational can somehow kind of have present side by side in medicine. I've been arguing for years that, it's the right thing to do. It's the kind thing to do. It's what patients want. It's what families want. I've begun to kind of deviate from that carrot approach to the stick approach, which is to say, if you don't do this, you sacrifice reputational capital. If you don't do this, and you can ask anybody who works, patient, representative will say, the reason people complain is not because of medical misadventure, which accounts for a minority of complaints. It's because, they felt like they were treated like a patient. And the irony is, even though we spend our entire professional lives learning how to look after patient. No one wants to be seen just as a patient, because patient is a generic designation as opposed to person, which is entirely unique and individual. So I'm hoping that the relational and the transactional somehow, make peace with each other in a way that healthcare also needs to include health caring.
Thank you. Question from the Zoom. I wonder if you can speak to your thoughts on providers as the custodians of hope. Is it our responsibility to maintain hope or frame hope or something else? And how do you reconcile our duties as they pertain to hope with our duty to attend to ensuring informed consent, being clear about our expectations regarding prognosis and function?
Is there another questions? I'm not sure that I followed all of the intricacies and the in and outs of the question, but let me just pull out one thread, which has to do with hope. We have studied hope in terminal illness, and one of the interesting things is that a minority of patients near the end of life actually endorse overwhelming hopelessness, which you at first think, well, that's really strange. I mean, if you have a prognosis that is hopeless, you would think that most people would endorse a feeling of hopelessness. And yet that's not the case. And so it seems to me that this is one of the few places in life where hope becomes uncoupled from kind of future expectation. Even people who have a limited prognosis maintain hope. What is that about? It's about meaning and purpose. So rather than thinking about, so how do I invoke hope? How can I sort of be this generator of hope, increasing, their serum level of hope? The idea, I think, in entering in the room is to think about connectedness, meaning and purpose. And again, that's going to begin by, I would say, intensive caring. Show up. Take an interest in who this person is. Know that when you step in the room, your very tone makes a difference. Know what's possible and be humble.
Thank you. Another question from the Zoom. What would be your advice to providers who are striving to provide this approach to care, but struggle with the required investment of time in an age where there are so many other commitments competing for our time?
I know that's a great question, and it's always a huge tension, and time, of course, oftentimes is exceedingly scarce. I guess I would say a few things. One is to know that whatever time you have, be mindful that you are with that person and don't be distracted. So in the time that you're there, make the most of what you do have available. Again, we know from the evidence that I've shown you that just by even sitting at the bedside, you can actually change the perceptions of the patient, and you can heighten their satisfaction with that encounter. I remember I was on a telephone call. I was asked to speak at the Mayo Clinics, and I was on a call with one person in the organizing committee, and we were talking about these things. And at one point he said, listen, I'm a busy neurosurgeon. I don't have time for all this. And I said, well, do you have time enough to ask somebody who they are as a person so you can look after them better? He said, yeah, I think I can do that. So the point is, it doesn't necessarily have to take a whole lot of time to make a difference. The other thing I would say is that, I mean, all of what we're talking about really is kind of a shifting culture. How do we shift the culture from healthcare to health caring? And I mean, my sense is that, yes, that needs to take place with individual clinicians and at the bedside, but also needs to occur in an environment where that is supported. So you need people to understand, those people who, are, the bean counters accounting for the bottom line, that this is something that is valued. And the evidence shows that if you don't do it, you sacrifice reputational capital. And if you don't do it as well, especially in this era of post-COVID, this is a healthcare system whose practitioners are burnt out. And so heightened job satisfaction will mitigate burnout. So there's a good financial case to be made for engaging in this kind of care.
Thank you. And last question, again from the Zoom. Working in a residential hospice, I often find when I ask people or when we ask people, what do we need to know about you to provide the best care possible? They often don't know what to say. I often wonder if it is because it's the first time they've been asked. I'm wondering how you elicit responses from individuals that are unsure of how to answer this question.
Great. So a real quick answer is, I think it was a month or two ago, I had a paper in the Journal of Palliative Medicine called Revisiting the Patient Dignity Question. And it deals exactly with that question. The fact is that sometimes people will hear that and say, that's kind of odd. That doesn't seem like a medical question at all. You have to remember that the question is meant to be the basis, the beginning of a brief conversation. And so I remember one gentleman began answering the question while saying, what you really need to know is I'm worried about how I'm going to be able to, manage and navigate the steps when I get out of hospital. I said, that's really interesting. I'll talk to your physiotherapist about it. But guess what? What I'm really wondering is, like, who are you? How is it that you want people to see you? And at that point, I mean, he was still scratching his head, and his wife, who was sitting at the bedside, finally turned and says, oh, I get it. He's the guy who everybody in the neighborhood comes to for advice. And he's also part of the choir, and he's a Mr. Fix-It. I said, yes, that is what I want to know. So if you find that it's not working, it just means that the patient, it's a strange question to come from somebody in medical practice, and to remind them that you're trying to shift the conversation to include something that is not traditionally medical, but has to do with, in essence, who are you?
Thank you very much.
So this concludes the Dr. Jane Poulson Lecture in the McGill Palliative Care National Grand Rounds Lecture Series, sponsored on this occasion by the Montreal General Hospital Foundation, where we are today. We're so grateful for Dr. Harvey Max Chachanoff for his expertise and his time with us today, and to all of you for attending. We ask you to please complete the evaluation form that you can access with the QR code that we will send to you, I guess, since we've disabled the chat, and that we will send to you by email as well.
We look forward to seeing you again on October 15th when Dr. Maria Baquitas will speak at the Research Institute of the MUHC. Thank you, everyone, et à la prochaine.